Good morning, everybody. We're going on with a very lively session on the OSK sessions today. Dr. Oscar Onyango, retina specialist at Kenyatta National Hospital and Nairobi Hospital. We also have Dr. Mukiri with us. It's a very rich faculty as it were. Dr. Mukiri is an anterior segment specialist at the University of Nairobi. We also have Dr. Betts, who's an anterior segment specialist at Moi Referral and Teaching Hospital. So we'll take you through the next session of anterior segment and retina. We're just looking at the charts as they're going on. Feel free to be still sending in any charts if you want anything answered, and we shall take it from there. I think we'll have the benefit of some of the speakers you watched earlier who might send in something, and we'll be able to make it as lively a session as possible. Dr. Mukiri, you had something to wanted to say?
Yes, good morning and good afternoon, depending on where you are. Just before we proceed with the live session, there's a few housekeeping announcements. So once we finish with the live session, do not exit the app, remain within the Move app, because after this, we'll have a talk from the Gold Plus sponsors from 10:50 up to 11 o'clock. And thereafter, immediately after that, we'll have the closing ceremony and the awarding of the award ceremony, which will happen from 11 o'clock. And please feed in the feedback. It's a questionnaire, a survey, so that the organizers can get a feel of what this experience was. Especially this is the first time we're having an online conference, and especially on a different app that we are used to. So don't leave, just make sure you continue up to the very end and get the great experience you have had with this session. Thank you.
Dr. Betts. Hi, can you hear me?
It takes a longer time for sound waves to reach you from Eldoret. Welcome to today's session. I think it's been a lively morning. We look forward to you asking as many questions as possible so that you can learn as much as possible. Welcome to this Q&A session. Thank you, Mr. Chairman.
Okay, great, Dr. Betts. Straight to the questions. In fact, Dr. Mushai's presentation on giant macular holes has really evoked lots of interesting discussion. I think there's a question on, would you consider macular surgery for large partial thickness hole if visual acuity is 624 better? A lot of this comes down to the experience of the surgeon and what the patient really wants. You don't, there's always a risk you can end up with deteriorating vision after your surgery. So you discuss with the patient, and depending on your experience, a partial thickness hole means you still have quite significant outer retinal layers that are viable. So 624, yes, it can be done, but comes down to your experience and the patient expectations. Of course, aren't the best for everyone. Secondly, the maximum duration after someone has had macular hole surgery. When do you decide to do surgery? When do you decide surgery is beneficial after you've had macular hole surgery? I believe this, depending on which gas you've used, you have 2 to 4 weeks or so, and able to tell if the surgery was beneficial or not. In retina, we normally have a joke about knowing when surgery is successful. You celebrate 2 to 3 months later. You don't give it 1 month. You know, like when you get an anterior segment, you have the next day everybody is happy. It doesn't work like that for us. There's also something, minimum vision cutoff before considering macular hole surgery, 612, 618. Again, it depends. Expectations. What are you trying to achieve? Yeah, well, we get the theory of you don't want to cause harm to the patient. You always want the best for the patient. You come secondary. It's all about the patient. Yeah. So 612, honestly, I would wait. I mean, fine, a bit of contrast sensitivity issues might come with that, but I would really tell the patient, let's observe and see. Sometimes holes have spontaneous closure depending on what caused them. Yeah, most of them are idiopathic, as it were, as Mushai's talk was mentioned that. But all in all, it's a matter of, it comes down to what the patient wants and the experience you have with ciliary macular holes. Failed closures happen with all of us. I've had several, and in fact, one of the patients I think presented by Gashago had come from me. And it is good to mention that to the patient. Would you consider central visual field analysis to record scotoma reduction? If you have I mean, many of these things are academic, so to tell the patient this is how exactly you're seeing, and the patient sees, yeah. So you're actually identifying with what I'm seeing, so that once you've done the surgery, you see this is much better, and objectively, the patient really appreciates that. Yeah, so that's okay to do. I think that's enough on macular. We can talk a lot of things about retinal grafts and things like that for giant holes. I think Mushai alluded to that. There is our colleague in West Africa, Dr. Okonkwo, who's very famous for that one, trying them. And lots of experience needed, lots of patience on the patient, but they do work. Dr. Mushai, what else do you have on your side? Sorry, Dr. Mukiri. No, Dr. Mushai. Dr. Mukiri, what do you have on your side, Dr. Mushai? Sorry.
Okay. I'll take you to the next step where we had several presentations on innovation, new technologies. So we had Kibata's presentation on the fundus camera and what the impact it has, especially when it comes to screening. And he zeroed in a lot on diabetic retinopathy, which what is the camera being used for quite a lot in many of the studies. What has been the experience in Kenyatta or on your side, because you deal a lot with diabetic retinopathy? And what is the future? What do you think is the future for it? Is it something you can rely on? Can the technology change? Because now we're having smartphones coming in, and because of the cost of fundus camera is not cheap, and we need to get these services out to the farthest place, as much to reach as much people as possible. What is your take on that?
Thanks a lot for that, Dr. Mukiri. Yeah, the mobile for the fundus camera, the mobile camera, which it's really revolutionized diabetic screening. We had the camera at the teaching hospital, yes, and it really changed things because people are going for diabetic screening with their physicians, and then they're told go and have your picture taken of how your eye looks inside, and that really gave people a perspective onto what retinopathy is all about. And because once someone sees any form of bleeding, any form of, then actually the person who was bringing the pictures, he was a former support staff who went for training, and he really learned how to focus the camera. I know it tells you don't need someone with a degree in, I don't know, photography or something like that. It's just a matter of someone who has a psych for it and has an interest for it. And he actually even started explaining things because he went for training, I think, in Zambia, and they met several other technicians there, and he came back and he's done so many. He's very good at focusing, and the pictures were clear. So the patient is sent from the medical clinic upstairs to us, and so you intervene earlier. You intervene early, even if it's non-proliferative. You're giving someone a review of a year or so, but they know 1 year down the line they need to be seen because they have seen somebody who's lost vision from diabetes. Then the other side of it is the concept of telemedicine, which also is really catching all over the world, not only in developing, but also in the developed world. So you have a camera-based, whatever, you can imagine any peripheral center, whatever, whichever country you are. And pictures can be done and sent through different media. I'm a very famous supporter of the mobile phone fundoscopy because of retinopathy prematurity screening that we do. And in an adult, it's even easier to do a picture for the diabetes and sending it on WhatsApp, on Telegram. The good thing is, like in East Africa, there's a lot of penetration of the mobile phone and lots of Wi-Fi or bundles, as it were, in different places. So there's no excuse now for diabetic screening in most centers within East Africa. I'm not sure about other parts of Africa. I know West Africa has had challenges here and there, but they also have different aspects of that coming up. In terms of diabetes screening with a mobile phone, with a mobile camera, mobile phone, the time is now. There's no excuse. Whichever center you are, it's the onus of the health of the department there to make sure you have trained somebody and asked people from Nairobi or people who do it anywhere near you to do pictures and send it to the relevant people, and we can advise treatment and initiate. But it is time for that, as Dr. Kibata mentioned in his talk. Yeah.
Good, thank you for that. I've also come across certain articles where the software itself has got artificial intelligence. It can diagnose or pinpoint hemorrhages, exudates, and all that. So it goes a step further in reducing, just using a technical person, not really an ophthalmologist, but a technician can do it and more accuracy in diagnosing those things.
Yeah, sure.
The other, okay, thank you. I want to switch to Dr. Bett, the master of anterior segment. And we had a presentation with Dr. Joyti on perfection, the journey to perfection, where we bring in cataract surgery. How can we minimize the post-op refractive errors? And she mentioned a lot about new IOLs, premium IOLs, doing good biometry. So Dr. Bett, in your experience, how accurate is your biometry in your center? And when you go for outreach, how many people, what percentage of people actually use biometry? Or do they just use average IOLs like when people go on safari? Dr. Bett?
I think that was a very nice presentation by Dr. Joyti, very enlightening. And I remember last year, somebody mentioned in our groups that it is unfair if you do cataract surgery without biometry. And you still find quite a number of places are slow in picking up that. But biometry is a human rights issue. It must be done for all cataracts where possible. In our situations, we are helped by either biometry and also the quality and the variety of the contact, then intraocular lens that we're able to implant. And combining Dr. Joyty's presentation with the femtosecond presentation, I think the quality of outcome of cataracts are bound to be better if we're able to construct a good wound, if we're able to do a good capsulorhexis and manage the nucleus well. Together with the biometry, we should be able to get very good vision post-cataract. Coming again to that, when you talk about quality, then if you are able to assure good outcome, then we should be able to deal with earlier cataracts before they become mature. And therefore, people who are professionals like me and you should be able to go for early cataracts as they get cataracts because of this development in technology and experience development. That's my take from the presentation.
If I may add,
please.
if you allow me, I'm thinking for cataract, to perfect cataract surgery, numbers are very critical. The more you do, surgery is an art. The more you do, the better you get, So we really have to encourage colleagues, even amongst ourselves, much as we focus on so much on subspecialty as retina, etc., but to encourage as many people as possible, because cataract is number one cause of reversible blindness in the world. I mean, it's not going anyway. If at all anything, populations are surviving longer, so everybody must know how to do a phaco, a standard phaco. Leave the complicated stories on the sides, but standard phaco, everybody must have an idea how to do that. Whichever center you are, the machines are cheaper now. Even getting second-hand machines are there, so there's really no excuse for someone. You must do phaco.
Okay, that's a challenge to all the training facilities that they must upgrade from SICS, although it's still important. Now we must go a step further into doing phaco. So everyone who's graduating should know at least how to do a phaco. And also with if you look at the femtosecond presentation, when we upgrade to better vision, putting in ICLs, then you get a cataract. He demonstrated about what complications can arise. If the patient now develops a cataract, how do you go about it? You remove the ICL and then do the cataract. You do it with the ICL in, like his presentation. So with increased technology, new challenges also arise.
Actually, if I could ask that, Dr. Mukiri, had a patient the other day. He is, I think, from Tunisia. He came with a retinal detachment. We did, he had an ICL and he was myopic, etc. But we did retinal detachment surgery, silicone oil, the work. So it was a huge tear. Those were the multiple tears. Then, at the point of removing the oil, now he had posterior subcapsular cataract with the ICL and the oil. So I discussed, as a retina person, my interest is the oil. But he tells me now, what about the ICL? Are you going to touch that? I say, I need the anterior segment surgeon to be with me in theater. He didn't like the idea of somebody that's been there. So I removed the oil. I left him with the cataract and the ICL. He'll be looking for one of you guys very soon. What's your take? What should have happened?
Unmute Mukiri.
From the presentation, the cataract was done with the ICL in situ. So I think there are still ways in which it can be done without touching the ICL. So my expertise does not reach there, so I cannot comment much on it. I have still a lot of learning to do in that area.
Similar. I hope the presenter is watching this. You could maybe post a comment there, see what we should Onyango have done in this situation. Things get more complicated the more technology comes in, but we must go there.
Okay. All right, great. Let's see. I'm just looking at more comments here. Dr. Mahesh from Lions, great guy. Did a talk on management of retinal vein occlusions. There are also some comments on that one. I believe we deal with this. You meet this even as anterior segment surgeons. The treatment anti-VEGFs have really altered the field of management of that. Presentation is critical, and of course, systemic workup is critical. Is there anything from an anterior segment perspective, if I can ask Dr. Bett now, if you see central retinal vein occlusion, there's no retina guy, your colleague, Dr. Situma, is not available. What do you normally advise your younger colleagues to do? Because there are people here who will need to know that. You don't always have us retina people near you.
Just by being an ophthalmologist, you will have to meet these challenges. I think currently we have 2 patients in our clinics. And so we know the goal of management. The textbooks say what the goal of management is. I think anti-VEGF, we have been taught, all of us, to be able to give anti-VEGF, but at what point and for how long? Those are the things that maybe we'll need to listen to you, the experts, the gurus. Yeah, because the more we give, it makes financial sense for us. But is it for the patient's benefit? Yeah. So I think that presentation was also very nice. And with your additional input, Dr. Onyango, it will fine tune some of the things that we do out there.
Yeah, I tend to adopt a more of a treat and extend kind of regimen, depending on how much macular edema you started off with. And the loading dose, I always give 3. The loading, that's standard. Then after that, depending on how much edema, how much what you continue, I extend. I give a difference of 6 weeks, then 8 weeks. The farthest difference in injections is normally 12 weeks. And most cases, within a year or so, you'll get very good macular contours within a year or so. And you've probably given 6 injections or so, 7 injections. But the cost, definitely, if someone has insurance, it works better. They still, I mean, sometimes they're forced to make, so started off with probably ranibizumab, and money went down the drain, and you end up with bevacizumab. There is always something you can give. Okay, there's always something you can give there. Yeah, I've actually tried steroid once, triamcinolone in a pseudofake. He couldn't afford the dexamethasone implant. And it seemed to give some response. Pressures fluctuated a bit, intraocular pressures fluctuated a bit, but there was something on the edema which resolved with that also. But the thing is, those are lifetime follow-ups. That's the other thing. You can have edema resolving now, and in 8 months, 9 months, it's back. And that's when now the PRN kind of dosaging can also come. So you see, you're mixing treat and extend PRN, depending how that goes. Yeah, there's a role for laser. Not too commonly for me currently, but there is a role. For example, if you're out somewhere where you probably don't have anti-VEGF. I remember, like in Kenya, we have lots of laser machines, photocoagulation machines in different aspects, different government facilities. If that is what you have, you can start off with that as you're waiting, and then
Yes.
yeah, that is at least reducing the VEGF drive. Yeah, there's always
Well,
something you can do. Then always remember to work with the physicians. Always, always. That's a very critical point. Very critical, because there are things that you can find. We find atheromas in the carotid, vegetations in the one of the valves. I can't remember which one that patient had. Many of them, blood pressure, sugar, play the critical. 90% of blood pressure and sugar, but you'll still have those thromboembolic stories, kind of thing, which really really are important. Those are life threatening, leave alone vision threatening. You know, I mean, you can imagine you're treating somebody for CRVO, then they present with a stroke, full blown. And for what I normally tell patients is just to tell them how serious this is. You've gotten a stroke of the eye, if that's the best way of putting it. And that really terrifies. When you send them to the physician, they will go, which it is basically. Yeah. But yeah, as I rightly say, all ophthalmologists can handle. There's something you can do. And nowadays, we've talked about the mobile phone issues, telemedicine component. It's very possible to communicate. I mean, I get pictures all the way from Nigeria. I mean, the world is a global village, as it were, and there's always something, and I consult too. In fact, I remember Ghana, Kwesi, some of my colleagues there. We communicate a lot. So Kruger in South Africa, when I'm not sure about something, then we have a forum for us, African Retina Society WhatsApp group. It's almost full, I think, by now. Which keeps us going. When there's something unclear there, put it there, and you will be amazed that, you know, sharing an idea, sharing a problem there, maybe adapt. Sharing a problem, it actually shows you're caring for the patient and they also want to learn. Yeah, so we do a lot of that, and it really works well. I'm not sure if in cornea, when you have those dystrophy cases or something like that, do you share pictures amongst yourselves or something?
yes, we do. But just to make it more clearer, you've mentioned edema
Mhm.
severally.
Mhm.
When we sat with you in the same room managing a patient, that's a long time ago. The methods for measuring edema were far at that time. What do you do? What do you mean by monitoring this edema? What mechanism are you thinking about?
We rely a lot on the OCT. Now, the optical coherence tomography scan, which is again is getting more and more available in more places. If you don't have, if you don't have an OCT machine, you have to rely on a slit lamp examinations, right? Going back to basics, using the 90, okay, and you'll be able to tell there's a swelling at the macula, there's no swelling at the macula, and of course you're telling this with the vision, telling this with the number of hemorrhages. The more hemorrhages you have, we've talked about ischemic and ischemic, whatever type of CRVO. So this clinical judgment comes. It's not that any patient you see it's been referred CRVO, you're sending for OCT straight. No, you have to examine the patient. You dilate, look inside there. Sometimes it may not even be CRVO. I've seen a leukemia case that was referred to me as CRVO. And actually, the other eye had more hemorrhages peripherally more than centrally. So you see this, you start thinking, what more is going on? And this turned out to be leukemia actually. At first presentation as different hemorrhages with a rock spot kind of hemorrhages on the fundus. So examination is critical. Slit lamp skill is still there. That will be with you. That's the stethoscope of the eye. It will be with you till whenever. But OCT definitely helps you. And even OCT helps the patient. Even the most basic, get a time domain OCT. Those ones I believe right now even much cheaper. Many might even get it as a donation, of course people are doing away with them. So you get something that shows you a swelling and the patient's relative or the patient can see with a good eye, there's a swelling here, then we start a treatment and down the line. There's nothing more. In retina, we rely a lot on imagery. A lot. When you show pictures, even just a simple fundus picture with a phone tells a thousands words. So once you do that, you find you are communicating well with the patient, and the patient agrees to the care you're offering them, you're at the same communication level. And you'll always tell the patient when a complication occurs, you tell them. Outcomes, you tell them. Expectations, you tell them. Someone coming with CRVO with the neovascularization 6 months down the line. I mean, this will end up probably with the glaucoma people at some point, our glaucoma colleagues, So you do be a bit, reduce the VEGF drive, etc. But tell them now, this one, when vision, we're not preserving so much, but we're trying to give you something to work with. We're not going to improve it to 6.6, for example. Yeah.
I think you mentioned something that we cannot overemphasize, working with other professionals, especially physicians. We had a case of a branch retinal vein occlusion. We couldn't get a risk factor, no hypertension, no what. Sent to a physician, and he came back and told me, this guy smokes. He hid it from me. He was a friend of mine. So I think collaboration with others, like you said, is a very important thing. The other issue is the phone camera, the imaging, especially the anterior segment. I think we've really had, for us who have access to our field of specialization, the phone camera has come in as a very important thing, both for sharing, for consultations, and for sometimes decision making, for counseling and recording. So I think the phone camera has really revolutionized the ophthalmology, especially anterior segment practice. And you mentioned that very nicely.
Yeah.
Thanks.
Okay, well, we're going on well. Very good. We just switch gears a bit. We still stick on the retina. There was a talk again by our colleague, Dr. Mushai, on OCT findings in staggards. Of course, retinal dystrophies, inherited retinal diseases are legion. We are seeing more and more now. People are getting more enlightened by that. And what probably would be interesting here is correlating OCT findings and electrophysiological findings. We are in the process of trying to work something out, okay, where we'll be able to do that. And it'll help because retinal dystrophies, whether they're talking about cone, rod, or mixed, a lot of them tend to be mixed. Even Stargardt's being predominantly a cone dystrophy, whenever you do electrophysiology, the full field ERG, you'll always find an element of a bit of scotopic losses also, especially for the advanced 40, 50-year-old cases. Yeah, I don't know if you guys have any exposures to this from the anterior segment, because for us, we can talk about retinal dystrophies for like the next 3 days.
What is the spelling of Stargardt's?
Mukiri, let's leave Dr. Bird out of that one. Mukiri, any comment on that one?
No, we do have anterior segment dystrophies, but once we see something abnormal in the retina, we just say, okay, this is for Dr. Nyango, Dr. Mushai, and we push it forward.
Yeah, because we are really trying to look hard. We're trying to get collaboration with institutions that do gene mutation screening, whole exome sequencing, as I call it, etc. And once that is done, that will give a guide, because you'll find cases where you might be having other issues going on in the body. Because some of these inherited retinal diseases are syndromic, the Ushers and the whatever the other conditions that you know. So you find you have one thing in the eye and something else going on, and it really helps the patient know what's going on, and it helps with family counseling. It helps knowing what kind of gene mutation you have, is it autosomal recessive, dominant, etc. Chance of you spreading it to your offspring, your children, if you have to get children. So it really guides you, But OCT is where we're starting off from. We have electrophysiology also now, both full field and multifocal ERG, depending on what you want us to look at. And it does well. I'm really excited by this. Looking forward to working with you guys also, because I know whatever gene mutations we'll get, the unfortunate thing in Kenya, we can only screen for mutations that are already known. But we need to screen for new mutations, because when you communicate with guys around the world, each population, each community has its own unique gene mutations. Some have similar phenotypic presentation, others have variable, so you can have a same gene mutation with a different story on the other side. But it will be interesting. I'll be keeping you guys posted on that one. Watch this space closely. Mushai, sorry, Mukiri. I keep calling Mushai. Mukiri, what did you had something to say?
Now, I think it's the same with anterior segment. The only advantage probably we have is that probably we counsel the patient on whether or not to expect progression and reduction in vision, and then we just do necessarily if it's very poor and the patient is really suffering, then you do a corneal transplant. But
that's definitive.
Yes, so that is probably the advantage we have in anterior segment. That aspect.
Because we have some forms of treatment for, you've heard about this RP gene, Luxtana, which costs about, last time I had, I think it was about 15 million Kenya shillings. That's, I can't remember how much of that in dollars, to try, but it's for a specific gene mutation. There's some oral medications that are tried also, different things that are being tried for various retinal dystrophies. The stem cell issue, which I believe you guys also do a lot in anterior segment, that people are trying that too. So there's hope. The only thing is our patients will ask me, like every 6 months or so, guys keep calling me. When are we part of that study? When, it has to be something so well thought of, well worked, so that, I mean, if you tell someone something about a gene mutation, you have to be sure exactly what kind of gene mutation and the manifestations expected from it, and it has to be true. And it has to be whether there's cornea involvement or not, whether there's other hearing issues involved or something like that. Anyway, that's retinal dystrophies. Okay, there's more talk, Mukiri.
There's one more talk which I saw, very interesting and very innovative. It's about 3D printing. I think, the presenter gave various aspects in which it can be used in ophthalmology, like in orbital plates. Let's say if there are fractures that need to be repaired or any defects in the orbit. Pupil expansion rings, remember those ones? In case the pupil is posterior synechial and you want to expand. Smartphone holders, remember we talked about getting good photos via the state lamp. So the holder to hold the phone and take good photos. Even making of forceps as well. So I know in University of Nairobi there was a innovation project called iHub, where they had 3D. One of the things was 3D printing, mainly used in architecture, where they were making the models of how a house would look like. But in ophthalmology, so far in Kenya, I haven't seen. I don't know if you have seen any, Dr. Bet, Dr. Nyang.
Dr. Onyango, please.
Sorry, the sound was not so clear. The comment was on what? I didn't hear you well.
It's on 3D printing. Using 3D printers to make certain things of interest.
Well, in the funders, we don't. The retina funders, we don't have much experience with 3D printing, so to speak. I've seen that in other aspects of surgery, but not so much in there, like spinal and neurosurgeons and plastic surgeons. I know a lot of that happens. Yeah, but in terms of retina, I don't have any knowledge on that particular one. Yeah, I guess, but once a global village and more is coming up gradually, so watch this space. In another year, we could be having some 3D print of different layers of the retina and what you can transplant from else, what you cannot, even if it's neural tissue. Nothing with the stem cell stories, anything is possible.
It will be a very exciting field in the cornea transplant if we can get an artificial. I think there's a lot of research on artificial cornea. And I think
yes.
3D printing will come in as it develops to be a very useful tool. And if we can get to print our own corneas, so that you don't have to get people donating or importing or something like that.
I guess one other aspect is in training. Let's say in the wet lab where you can get people can gain experience using that before they actually go to the live patient.
That's true. There's still lots to be done out there. Yeah. I just wanted to switch gears a bit to modern day medicine. Yeah. Any changes, any ophthalmic findings of COVID reported anywhere so far? I've had calls, I've had pictures sent to me of what looks like follicular conjunctivitis or something like that. People with other, fever and chest. Of course, it's sent to me on picture. I mean, on phone. I'm not anywhere near that, and it's a viral kind of conjunctivitis, so to speak. But you can't be sure does coronavirus give a viral conjunctivitis, or these are just coincidental findings in someone who also has COVID-19 infection. Have you had any experience with that? I just switched gears slightly from what was presented today.
Well, I've seen quite a number of viral conjunctivitis. We don't know if the patient has COVID or not, but there's one patient I know I met, I think, 3 weeks ago, who was discharged from being, had COVID, was admitted, stayed in hospital for about 3 weeks. The day on discharge, he got very red eyes, and he came to my clinic. And when he said he was just discharged because of COVID, I almost ran out of the room because it was so scary. Because the eyes were red, it was tearing, it was everything. So you're not too sure, is this very active? Because I asked him on discharge, did you have the COVID test on discharge? He said no. So you don't know if he's negative or positive still. So I'm still crossing my fingers, but 3 weeks down the line, I think I'm safe. But generally, it was just the cornea was clear. It looks very similar to the adenovirus conjunctivitis. Intense redness on the conjunctiva, edema, a bit of pain, and sensitivity to light. Of course, you don't want to examine them much, so we can't get much clinical features after that.
Yeah. I mean, our practices have changed a lot now. Sorry, Beth, you wanted to say something?
No, as it is now, I've not noted an increased incidence of conjunctivitis. In spite of us knowing that there's so much COVID going around, we've not noted more conjunctivitis presenting to our clinics. So I think still, well, if that element is there, it's not a very prominent element as to change the statistics that we had before. I don't know. What do you think? Do you think you've seen more conjunctivitis as COVID became more?
No, I'd say I'll send pictures, I think 2 times. And I mean, management viral conjunctivitis is conservative anyway, lubricants. So that was fine. But what I'm also wondering is, this thing is there with us. In terms of surgeries, are there any special precautions you guys are taking when you're doing surgeries now? You assume everybody is COVID positive, and so how do you handle your intraocular surgeries now? Is it any different from before?
In our core hospital, I think we have had 3 patients we have operated on as emergencies who turned out to be positive later, because we do COVID for everybody. But for emergencies, we don't wait for the results. So you operate today, and 2 days later, positive. It is about just assuming everybody has COVID. That's for my protection. But in terms of ocular surgery, I don't think we've changed any of the things, because we still consider cataracts to be an emergency, and bilateral cataracts to be an emergency. So we still do them. We've not changed the way we do it. The other thing is, I think for our own mind, we've been doing very good draping with those, with the one with the glue, with gum around. So at least the patient breathing is kept away from you. In our theaters now, we have, I don't know whether to be able to be vacuum, those vacuum things. This one.
Yeah, we see it. Good. Yeah, we see it. Yeah.
Yes. So that, well, just to try, and we don't know the effectiveness, but we're just giving ourselves a second chance. Yeah. And all through, none of our theater workers has been affected. So we may be doing, so those are the changes that we've had to do to our surgeries.
No, thanks. Thanks a lot, Dr. Beth. That makes a lot of sense. I think our time is up. Dr. Mukiri, you had an announcement to make at the end of
Just
this?
a question. There's a question from Inoti about regarding OCT versus SLE fundoscopy diagnosis of DME, as earlier taught before OCT got there. Would one be justified to do anti-VEGF without OCT when convinced of the need? Maybe.
Yeah,
Just
center involving macular edema, you'll treat. Yes, you don't wait for OCT. Center involving. Now, our time is up. I wanted Dr. Mukiri. Dr. Inoti can get in touch. Dr. Mukiri?
Okay, our time is up. So just
is it me or him?
Oh, he's frozen. I think it
Unfreezing.
was regarding the announcement. People shouldn't sign out at the end of the
after
session.
this, don't leave the Hoover app. Go to the next session, which is a Gold Plus sponsor, which is about 10 minutes from 10:50 to 11. And immediately after, there will be the award ceremony and the closing ceremony at 11. So keep on the WhatsApp, Hoover app, and also please fill in the feedback survey form so that the organizers can get a feel of what is your experience during this conference. Thank you very much for keeping the session lively, for the panelists, and also for the people keeping on. Thank you so much.
Thank you. See you later, guys.
Thank you.